Okay, we can start. Good evening, everyone. We are very happy to have with us today Professor Shripad Devalkar. He'll give us a research webinar on cost effectiveness of seroprevalence-based COVID-19 vaccination strategies in India. Shripad, I have been known. I probably know Shripad from 2011 when Shripad was in the job market. I remember he visited Wisconsin as well, and that was the first time I got to know Shripad's work. And I'm closely following all of his work in nonprofit and other. It is fascinating work he has been doing. So Shripad is an associate professor of operations management at the Indian School of Business, and his main research interest falls under the broad themes of nonprofit and public sector operations, agriculture and food supply chains, predominantly responsible supply chains, I think, Shripad. And in these thematic areas, he's also interested to understand how the interaction of operational, financial, and risk management decisions affect outcomes. So it's clearly an interesting phase with the interface of operations and finance. So prior to starting his academic career, Shripad was a consultant with a supply chain consulting firm. And Shripad has a PhD degree from Stephen M. Strauss School of Business at the University of Michigan. And he's also an alum. He does MBA from Ahmedabad and a BTech from IIT Madras. So without taking much time from Shripad, I'll give the floor or the virtual floor to him. And Shripad also mentioned that he's willing to take questions as he goes to the seminar. So I will keep a close watch of the chat as well. So if there are some pressing questions or any questions otherwise, feel free to drop them in the chat and I will ensure that we take them as you go along. Yeah. So thank you so much, Shripad, for joining us today, and we are excited to host you. Please, the floor is yours.
Thank you so much, Devjit, for that warm introduction and for the invitation to present at in your research seminar. As Devjit was saying, I'm an alum of IIMA Ahmedabad, and it's a great pleasure to be back at the alma mater. As I was telling Devjit just before everyone joined, it would have been even better if it was possible to be physically present on campus and experience what it is like to be standing in front of this in a position where I would have been facing students rather than be in the student seat, right? But hopefully that will happen sooner than later once the pandemic subsides. So I hope my screen is visible to everyone and you're able to kind of see and hear me clearly. So what I want to talk about today is the cost effectiveness of seroprevalence-informed COVID vaccination strategies. And I'll talk about what each of these terms mean in just a minute. This is a joint project involving many collaborators, and it combines both an operations modeling aspect as well as an epidemiological modeling aspect. So Nim Pati, who's at the Imperial College, and Sandeep Mandal, who's an independent consultant, are the mathematical epidemiologists on this team. Sarang, who's a colleague at ISB, myself and Abhishek, who's an RA working with us, have been involved in the development of the supply chain model. And this work is being done in collaboration with collaborators at the Center for Global Development. And we've had discussions with Dr. Rajesh Kumar, who's an expert and is an advisor to the state government of Punjab and is also a member of the National Technical Advisory Group on Immunization. So, with that introduction of all the collaborators on this project, here's how I've structured my talk. So I'll walk you through a quick introduction on what this work tries to do. I'll walk you through the details of the supply chain model, specifically the approach that we've taken, some initial results, and then how it ties in with the epidemiological model, share a bit of the model details, results, and then finally have some discussion around those results. So a few caveats right up front. I'm an operations person. I will be able to answer most and any of the questions that you might have on the supply chain modeling aspect. I'll try and do my best in terms of answering any questions that you might have on the epidemiological model, but that's an area that I clearly don't have much expertise on. And if there are doctors in the audience who have questions about the model or have concerns about the model, please raise them. I can't promise that I'll be able to address them, but I shall certainly make note of them and bring it up in my discussions with the collaborators. So everyone knows what the state of the epidemic is in India, right? So we had this huge second wave in April, May of this year. It caused a lot of angst. There were lots of, every one of us is familiar with the pictures of people being affected, beds being in short supply, oxygen being in short supply, and the significant number of deaths that occurred because during this wave. Hopefully, since then, the pandemic has been subsiding, and while there are talks of a third wave, hopefully it will be nowhere near as severe as the second wave was, or hopefully not even as severe as the first wave was, and we're probably seeing the last of the pandemic. And to a large extent, some of this attenuation in the impact of the pandemic has been a combination of many measures that various governments have been taking, vaccination being one of the prime ones. But compared to a lot of other countries, even if you compare to countries like Brazil, etc., the state of vaccination in India is still fairly low. So only about 15% of all the adult population in the country as of now is fully vaccinated, and probably closer to 50% has gotten about one dose. So in some sense, the way I would like you to interpret what I will present later on today is to think of it in terms of what could have been done in terms of implementing an effective vaccination strategy before the beginning of the second wave itself. And even with the kind of supply that's available today and the resources that are available to deliver the vaccines, could there have been a larger impact if the vaccination strategy was differently structured? So in that sense, the issues that we are trying to deal with as part of managing this vaccination is that there is limited supply of vaccines, and there's also a resource constraint. What I mean by resource constraint is there is, to be able to deliver the COVID vaccine, we need cold chain transportation, we need cold storage, and we also need trained human resources, that is vaccinators who can deliver the vaccines. And a lot of these resources are also in short supply. And so given the situation of low supply and low resources, how feasible is it to achieve this target of vaccinating 75% of the adult population, and especially by in the timelines that the government has set out, which is end of this calendar year. And in order to make the maximum use of these limited resources and supply, there have been various different solutions that have been offered, right? So the different countries have adopted different approaches. So part of it was fractionated dosing, dose stretching, where people who had gotten had an infection but given a single dose and their second dose was delayed, the time between two doses was stretched. What I will talk about in today's presentation is using seroprevalence to inform vaccine allocation. Or should we not give any consideration to seroprevalence, and should we just uniformly vaccinate all adults and see what that impact is? In terms of what seroprevalence means, and you probably have all heard this term in the context of the discussion around the pandemic, this measures the extent to which the infection is already spread in a population. So anyone who has antibodies is considered seropositivity, and seroprevalence estimates it at a population level. So in a given city or a given state, what proportion of the population in the state has been infected and therefore already has antibodies present, right? And should a vaccination strategy be tailored based on the seroprevalence in a particular region, and should some regions be prioritized and others not so much? And given that there is scarce resources and scarce supply, how should we do this allocation? Is it better to allocate it to high seroprevalence regions? Is it better to allocate it to low seroprevalence regions, because they both have very different implications? And implementing any of these strategies costs money, and money can only be spent once, and therefore it is important to understand the best way to spend this money. And the way we do this impact assessment is by looking at the cost effectiveness of various interventions. And just to kind of give you a brief overview of what we mean by cost effectiveness, think of intervention and a comparator. Think of the comparator as a baseline. Say, for example, this is the case where no vaccination is undertaken. An intervention is a particular strategy of implementing vaccination. Now, associated with every intervention, there's a cost of the intervention, and there is a health gain because of this intervention. And similarly, for the comparator, there is a cost of that comparator. Now, you could as well think of the comparator as the actual implementation of the vaccination strategy, or some uniform vaccination strategy, if you will. And similarly, evaluate the health impact of the comparator strategy. And the incremental cost effectiveness of the intervention is nothing but the difference in the cost of implementing the intervention in the comparator to the health gains that are achieved. And this is one form of economic evaluation of different healthcare interventions. You could think of other metrics also in terms of choosing or ranking different interventions, right? So what kind of questions can be answered with a cost effectiveness analysis such as this? Well, as I said, which are the risk groups that the vaccine is most cost effective? So for example, every country, when the vaccine was rolled out, it was first rolled out to the elderly, who are most vulnerable, people with comorbidities, and only then was it opened up to general population. And so to what extent should such prioritization be implemented? And what are the health outcomes associated with implementing such a strategy? What are the costs associated with implementing that strategy? Another kind of question that one could ask is, which is a more effective vaccine? Should we be using the Pfizer vaccine, or should we be using the AstraZeneca vaccine? Or should we be using Covaxin? Or is there a mix of these different vaccines based on their effectiveness, based on their availability, the resources required to distribute these vaccines? Which of them is most cost effective? The specific question that we set out to answer in this work is, given a specific vaccination, what's the most cost-effective way of implementing that vaccination? For example, should we be targeting rural or urban areas first? Should we be targeting areas which are hotspots where the disease is showing rapid increase, or should we be focusing on areas where the disease hasn't already spread, because that's the region where there is a significant section of population that is potentially vulnerable to infection, right? And should it be based on available supply? Should it be based on available capacity and so on, right? So you could think about many different criteria based on which an allocation strategy could be designed, and then measure the cost effectiveness of implementing such a strategy. So the research question that we set out to answer is, what are the implications of implementing different seroprevalence-based prioritization strategies? We measure it along two dimensions. One is, you could think about what is the reduction in incidence of the disease, that is, how many infections does it potentially reduce, and the mortality. So how many deaths could it have prevented because of having implemented a particular strategy? And what is the overall cost effectiveness of such a vaccination strategy? And the motivation for thinking in terms of seroprevalence-based strategies, and we use Punjab as the case study for our work, is at the end of the first wave, sometime around August and September of 2020, when a sero survey was done in the state of Punjab. What was found was, in urban areas, there was a seroprevalence of about 30%. What this means is, out of every 1,000 people residing in urban areas, roughly 300 of them had been found to have antibodies. Whereas in rural areas, the seroprevalence was lower of around 20%. And so retrospectively, in terms of the vaccination rollout happened the way it happened. But if one could have done an analysis prior to the rollout of the vaccination in advance of the second wave occurring, would it have been better to either prioritize rural areas because they had lower prevalence, which means lesser number of people residing in rural areas were infected and therefore were at a higher risk of getting infected if a second wave were to occur? Or should urban areas be prioritized? And the reason why there is a valid case of prioritizing urban areas which already had a higher level of infection is it's not clear what led to the higher seroprevalence. In the sense, is there just a higher transmission intensity in urban areas because of more dense population locations? And therefore, if a second wave were to occur, even though a larger fraction has been infected, the disease is likely to progress much more rapidly in urban areas compared to rural areas. And therefore, does it still make sense to prioritize urban areas? Or just do both together? Do not consider seroprevalence and just vaccinate them in some sense uniformly. One could think of an uniform strategy as vaccinate them at a rate which is proportional to the populations that are living in urban and rural areas. So which of these strategies work better? What are the costs associated with them? And what are the health outcomes associated with them?
So Sripad, there's a quick question here.
Sure.
The question is, what is the seroprevalence methodology?
So the seroprevalence methodology is there are so at the end of let's say a pandemic wave or in the middle of a pandemic wave, the government does creates a sampling frame and tests people, and this is segregated across, let's say, age, gender, located in urban areas, rural areas, and tests people for antibodies. And based on the sample that is tested, you will find a certain prevalence of the disease. You would find some fraction of people that were sampled who have antibodies present in them. And therefore, you can say something about what percentage within the sample was infected. And that is what one calls as, so at an individual level, this is a seropositivity status of an individual. Does the individual have antibodies or not have antibodies? And presence of antibodies indicates that this individual has been infected in a prior pandemic wave, right? And so when you aggregate it at a population level, without having to test every single individual, you can say something about what proportion of the population residing in a particular area is likely to have been infected. Hopefully that answers the question.
Yep, thank you.
So the approach that we take in this study is to determine cost effectiveness. We need to do two things. One, measure the outcomes of implementing each strategy and measure the cost associated with implementing that strategy. And the supply chain, and therefore we combine two models. One is a model of a supply chain that is used to deliver the vaccines under each of these different strategies. And the other is an epidemiological model, which measures, which is a mathematical model of the transmission dynamics of the disease, which then measures the health outcomes from following or implementing each of these strategies. The other input that the supply chain modeling exercise provides to the epidemiological model is also under each of these different strategies, what is the rate of vaccination that can be achieved given resource and supply constraints. And so let me start by discussing what the supply chain modeling does, and please feel free to stop me at any point if there are questions or things that aren't clear, right? So as I just said, the supply chain model is integral to evaluation of these strategies for two reasons. One is the cost. Unless you know what the resources involved are, to what extent they are used, you can't come up with a cost figure of implementing a certain strategy. But it is also integral in terms of what is possible under each of these strategies. Right? So let's take the example of rural first strategy or a low seroprevalence first strategy. What implementing such a strategy would mean is, when you have limited supply, you would want to first direct that supply to rural areas, and only after the target population in the rural areas has been vaccinated would that supply be allocated, would be used to vaccinate the urban populations or the high seroprevalence populations. But then knowing supply alone is not enough to understand or estimate how fast the vaccination can happen, because delivering the vaccine requires resources. And therefore, and this is very, if you are a supply chain person or an operations person, this is fairly basic, right? So every process has a capacity, and the capacity is going to also have an impact on what the actual achieved rate is going to be. Now, how you use your resources and what resources are available together determine what capacities are possible. Now, there are multiple ways to think about how available resources can be used, right? So one is what we call as a baseline scenario, which is all of the resources that are required for vaccination are currently deployed over the state in a certain configuration. Some districts, in some rural areas, in some districts, there is so much capacity available. In urban areas, there is so much capacity available. And if you don't allow for these resources to be moved across different districts or even within districts, then you have a certain capacity that's available to you to deliver the vaccines. And that capacity, together with the available supply, then will determine at what rate rural populations are vaccinated, and if all of the supply can be used to populate rural populations, to vaccinate rural populations first, because it's possible that the capacity in rural areas is much lower than even the available supply, in which case some of that supply could also be used to vaccinate urban populations in parallel, even though you're prioritizing rural areas. Now, alternately, what you could do is, because you want to prioritize rural areas, you could move some of these resources from urban areas to rural areas, for example, and therefore increase the capacity in rural areas, which would then allow you to use all of the supply that's available, and therefore finish vaccinating the rural areas faster and then move on to vaccinating urban regions. Now, you could take that one step further and say, why restrict it within a district? You could also move resources across districts. Now, obviously, redeploying resources, moving resources from one portion of the district to another or across districts is costly. And therefore, each of these different scenarios will have a cost associated with them. And what that cost associated with the scenario is also a function of what strategy you're implementing, because the cost of moving resources within the district is different. You might not need to move resources from urban to rural or rural to urban. And therefore, under some vaccination strategies, there might be a larger amount of resource redeployment. In other strategies, there might not be, right? Putting all of this together requires a detailed supply chain model, and that's what we set out to do first. I can pause here and see if there are any questions, and I'm happy to take those questions.
All crystal clear, looks like, Shripad.
All right.
But there's a comment, though. There's a comment from Sundaram saying that usually the antibody tested by ELISA technique. So I don't know. I think there is a special technique which mentions.
Yeah. So can I say it, Professor? Is it?
Yeah, sure.
Yeah. So it's a very commonly used technique for the testing the antibody titer. So I just added like what Dr. Sripad explained about the seroprevalence. So one question like I would like to have here, a very small clarification. So when we say supply chain resources, do we mean the cold chain requirements? Is that what we mean there?
Yes, cold chain storage capacity is one, but it also includes human resources, specifically the vaccinators required to administer the vaccines. plus the other vaccination team members, for example, to do the registrations and things like that. So it includes both human resources as well as physical resources.
Got it. Thanks.
So as part of developing the supply chain model, the key assumptions we make, and which are again motivated by what the government put out in its operational guidelines, are that India has a fairly robust routine child immunization infrastructure in place, which has cold chain resources as well as vaccinators who are called auxiliary nurses and midwives who do these routine vaccination sessions. And that forms the backbone for the COVID vaccine delivery as well. So we assume that the cold chain used for routine immunization will also be used for delivering the COVID vaccines. Moreover, what the government had stated was that the essential routine immunization activities, which is the actual vaccination sessions that need to be conducted to make sure children and mothers get the required vaccines on time, will continue to happen in parallel while the COVID vaccination is going on. And therefore, some of these resources will be utilized for routine immunization as well, and may not be available all the time for delivering COVID vaccines. And therefore, when thinking about the availability of resources for COVID vaccine delivery, one has to account for this utilization for essential routine immunization activities. And so that's what forms the first phase of the supply chain modeling exercise, which is one, estimating the resources, including human resources, that are available in total in the routine immunization supply chain. And for this, we largely relied on publicly available data. So the government puts out statistics on the routine immunization infrastructure, and I'll show them in just a second. But we also had conversations with state officials and district officials, immunization officers, to validate some of the data that we're using and inform more, where possible, get more granular data. And once we had an estimate of the resources available, we developed a supply chain model in terms of how the vaccines move through this cold chain. So what are the different stages involved? What is the frequency at which routine immunization vaccinations move across these different stages? And what the storage capacity available is and the storage capacity required is. And so we estimated the utilization of these resources for the delivery of routine immunization vaccines. And also, therefore, what is the cost incurred for the delivery of routine immunization? Now, of course, this is a modeling exercise, and this is informed based on what we could gather in conversation and publicly available information. And therefore, we also validated whether our supply chain model for routine immunization is a reasonable replication of what actually happens. And we did that again by sharing our estimates of the utilization with the officials involved in the immunization program to make sure that we're not way off. We also validated it by comparing the cost that we get from our supply chain model with the estimates that have been published in the literature in costing studies. So there are a lot of costing studies that have been published on routine immunization, and we want to make sure that the cost estimates we get are within the same in the same range as what has been estimated through ground up studies. Right? And once we do that, and once we have a reasonable understanding of what the resource availability and resource utilization are, we then develop a supply chain model for the COVID vaccine delivery, which uses the unutilized resources from the RI structure.
Sorry, there's a quick question. Can I ask?
Yeah.
So there's one question: has the model arrived at total resources required aggregated at India level, and scenario cuts in case of two strategies across vaccination timeline?
So no, this model that we've developed is specific to Punjab, but nothing. But the same approach could be applied to, say, for example, any other state in India. Now, also, if more granular information is available, one could do the same thing for an individual district within a state as well. What was the second question, Devjit?
That was pretty much it. So whether the model was aggregated or across two different strategies or at a scenario wise.
So I'll talk about the scenario-wise model in just a second. But in terms of the routine immunization vaccination, there is the actual implementation, and that's what we built a supply chain model to replicate.
Thank you.
Yeah. And in the second phase, using the unutilized resources from the routine immunization infrastructure, we estimated what the vaccination rates and cost for different vaccination strategies and supply chain scenarios are, which is what I'll discuss in length subsequently. Two basic assumptions that we made when modeling the supply chain for COVID vaccine delivery, because these are things that one doesn't have a parallel in the routine immunization supply chain, is one, how many vaccines can be delivered in a session? Because remember, routine immunization, the vaccines are being delivered to children, where it is possibly harder because children aren't still. And obviously also have a much lower pain threshold, and therefore administering a vaccine to them is more time consuming. Whereas COVID vaccinations, at least right now, are targeted towards adults. And so there will be a difference in terms of how many vaccines can be delivered in one session, if you think of a session as a day. The assumption that we made was that 100 COVID vaccinations can be done per session, and each session requires one vaccinator. And as I said, in terms of the population that needs to be covered, this is all adults in Punjab. So that population is about 2 crores, and the target that we have is 75% coverage, right? Now, coming to the routine immunization supply chain, there are 4 stages. So one is what is called as a state vaccine store, and this is starting within the state, right? Vaccines first come to a state vaccine store, and from there are shipped every quarter to district vaccine stores. Think of these as large storage facilities that are available in aggregate for a state and individual districts. And the district's needs are shipped every quarter from the state vaccine store to the district vaccine store. And from the district vaccine store, then shipped further down to what are called as cold chain points. And cold chain points are essentially those entities where there is cold storage capacity available. These include district hospitals, these include primary healthcare centers, urban healthcare centers, community healthcare centers, etc. And from these cold chain points where vaccines are stored, these vaccines are then taken by the auxiliary nurses and midwives, who are the actual vaccinators, to the individual vaccine session sites. Now, for routine immunization, the vaccine session sites include what are called as sub-centers. It could also include Anganwadis in villages, because this requires last mile connectivity, right? And the transportation between the cold chain point and vaccine session sites happens through cold boxes, because in each session you're looking to vaccinate about 30 to 40 children, and therefore the vaccines required can fit into a box, and these vaccination teams actually physically carry it with them, right? Now, in terms of estimating utilization and costs, these are the assumptions which we made. So the demand for routine immunization depends on what the birth rates are. And in Punjab, they're estimated about 15 births for every population of 1,000 people in rural areas, and about 14 in urban areas. And these have been all collected from published sources by the Ministry of Health and Family Welfare. So RHS stands for Rural Health Stats. The population that we considered are taken from the census and the rural health stats, and these were done per district. In total, there are about 750 cold chain points within the state of Punjab as far as routine immunization goes. The state might have augmented them for COVID vaccine delivery, but there is no credible public information that we could find any information on additional cold chain points that were created for COVID vaccination. And therefore, we assume these are the cold chain points available even for COVID vaccinations. ILRs stand for ice-lined refrigerators. These are used at the district vaccine stores and cold chain points, and they come in 2 sizes, small ILRs and large ILRs. Small ILRs have a capacity of about 45 liters. Large ILRs have a capacity of about 100 ILRs. And in total, across both small and large ILRs, there were about 1,000, little less than 1,200 ILRs in the state of Punjab, which are used for routine immunization and which could also be used for COVID vaccine delivery. Walk-in coolers are large cold storage units, which are typically used in state vaccine stores. And there are 6 available in the state of Punjab. And ANMs, who are the vaccinators or the auxiliary nurse midwives, there were about 4,500 of them in the state of Punjab. The other thing in terms of moving vaccines across these different stages, you need cold storage transportation. Now, we couldn't find any information as such on the number of vehicles that were available, but typically what we understood was every district has cold storage transportation, and these vans go to the state vaccine store to pick up vaccines and bring them to the district vaccine stores, and further on from there, deliver vaccines to the cold chain points every month. So what we did was we assumed that we calculated how many transportation vehicles would be required to transport or meet the regular routine immunization demand, and assume that that many transportation vehicles would be available. Now, one thing to keep in mind is this would, if these vehicles were completely utilized, this would mean that there is no transportation capacity available at all for COVID vaccine delivery, but that doesn't turn out to be the case because these vehicles are not used every day, and therefore there are days in which these vehicles could be very well used for transporting COVID vaccines. The routine immunization has a vaccine schedule. What it means is there are a prescribed number of different vaccines, different doses that need to be delivered to consider a child as being fully immunized. And in the state of Punjab, the schedule that Punjab follows, there are about 19 doses that need to be given. And for all these doses together, the volume in terms of cold storage volume to store all the doses required for one fully immunized child is about 78 ml. So once we know what the storage capacities of each of these cold storage infrastructure is, and we know what the net cold storage requirement is, we can calculate how many routine immunization vaccines can be stored in a given capacity and so forth.
So there are some quick questions, Sripath. Can we take these few?
Sure.
One is that does the supply chain model take into account the time gap between 2 doses?
Are we talking about routine immunization or COVID? So for routine immunization, think of it this way. Yes, there is a time gap between when these different doses need to be administered to a specific child. But then children are being born every year and they're being born throughout the year. And so at any given point in time, there are a certain number of children who would require, let's say, the first dose of the polio vaccine, some children who would need the first or second dose of the DPT vaccine, and so on and so forth. Right? So at any point in time, you have a certain number of doses of routine immunization that need to be delivered. And that's what uses the demand and therefore estimate the utilization of the capacity available in the routine immunization framework. Does that address the question?
Yeah, so my question is more for the COVID.
Okay, so I'll talk about that in detail, but for the purposes of this model, no, we don't take the time gap into account.
There's a follow-up question, which is, for the cost analysis, do we assume all our exactly vaccines the same? Because some vaccines would need, like Sputnik needs apparently sub-zero temperatures and all. So is there homogeneity across the vaccines?
So we assume that all these vaccines used for COVID vaccine delivery can be transported using the existing routine immunization supply chain structure. And again, if you think about it from an actual implementation perspective as well, initially the focus was on using Covaxin and Covishield, both of which for delivering both of which, the existing cold storage and transportation capacity facilities are sufficient. We don't model more specific infrastructure required to, let's say, deliver Sputnik vaccine, which might need additional colder temperatures, or let's say the Pfizer or Moderna vaccines, which require much colder temperatures. We don't consider that. Again, which is why the model has its limitations.
Sure.
And so when we use the data, the demand for routine immunization and the available capacity, what we find is there is significant variation in how much these resources are used across districts. So what each of these bar charts represent is the variation across districts in the utilization of a specific resource. So for example, if I think about the large ILRs that are used at district vaccine stores, then what this means is there are districts where the utilization is as low as 30%, whereas there's some districts where almost all of the storage capacity of ILRs at the district vaccine stores are being utilized for routine immunization. The other thing to notice is beyond variation in utilization of the same resource across districts, there is also considerable difference in the utilization of different resources. For example, if you think about the small ILRs that are deployed in rural cold chain points, they are used minimally across all districts together. And so what this effectively means is, one, which of these resources could potentially end up becoming a bottleneck for COVID vaccine delivery could be different across different districts, because different resources might be in short supply in different districts. The other thing is the fact that there is such variation in the utilization of these resources. There is the possibility of potentially augmenting capacity in specific districts by moving resources across districts. And these are the factors that we capture when we build the supply chain model for each of the different scenarios that I showed you earlier. I hope that was clear. If there are any questions, I could take those before moving forward.
Just a clarification question. Is the ILR similar to cryogenic?
These aren't cryogenic. These are more like, think about the freezers in your refrigerator. Because what you need is 2 to 8 degree centigrade temperature to be maintained. The walk-in coolers are more, have a much lower temperature of storage, because some of the routine immunization vaccines can also be stored by freezing them up.
That's clear.
Yeah. So beyond supply chain capacity, the other major determinant of the rate of vaccination is the supply of vaccines available. And as you all probably know, there has been no single source of information for what the actual supply of vaccines in the country has been. And so we've had to kind of, again, go back to multiple published sources. These include estimates published in the press, plus what the government has put out in the various press releases about the projected supply of vaccines, along with information that we gathered in conversations with policymakers. So based on that, what was also not available in terms of firm information was how the supply available at the national level was allocated to different states. And therefore, we assumed a fair allocation rule. And what I mean by that is that the total national supply was allocated to each state in proportion to the population in that state. And so if you think about the entire adult population of India, which is about 94 crore people, and Punjab has an adult population of about 2 crores, it means Punjab would be allocated about 2% of the total national supply every month. And this then gives us estimates of the total vaccine supply in Punjab starting the month of April, So for the first 3 months, April to June, the supply was about estimated at about 20 lakh doses per month. Increases slightly in July, and starting August, the supply was estimated to be about close to 40 lakh doses each month, indefinitely into the future. Now, it turned out when we looked at the actual vaccination numbers in Punjab from the data put out on the COVID dashboard, our supply estimates are not too far off from what the actual vaccination numbers are. So as you can see, the actual vaccination numbers in the months of April to August are quite close, but there is a temporal mismatch, right? So there are months in which the actual vaccinations are lower than what our supply projections are, and there are months in which it is higher. Now, clearly, this is what we have is a supply estimate, and it's not necessary that the supply was immediately available for deployment, and therefore there could be a temporal shift between when the vaccine is available to when it got actually administered, and that probably explains this temporal mismatch. But at least it was good to see that our estimates were not way off. What this slide also shows is, given how the various supply chain resources are currently deployed across the state of Punjab, across all the districts, across rural and urban CCPs, what we find is, interestingly, the capacity in rural areas is quite large. So if supply was not a constraint, using the resources that are currently deployed in rural areas, one could potentially administer up to 45 lakh doses each month in Punjab. And so what this tells you is, in rural areas, the vaccine administration capacity is more than sufficient to handle all the supply, even if all of that supply were to be directed to rural areas. On the other hand, the capacity available in urban areas is far lower. So even our lowest supply projections, which is about 20 lakh doses per month, are higher than what the current baseline urban vaccination capacity are. And therefore, this would already tell you that if there is a benefit from moving resources, it is likely to come from moving resources in rural areas to urban areas. Now, I would like to give some caveats in terms of these vaccination capacities that we've estimated. It has a fair bit of limitations, right? So in our estimate of the vaccination capacity, we've assumed that vaccinations can be conducted in all possible sites. So what this essentially means is, all of the sites that are available for routine immunization, like public health centers, urban health centers, community health centers, sub-centers, one could potentially hold a COVID vaccination session if all the other resources were available. That might not have been true in real life. That might not be the case in real life, because the way the actual vaccination is being implemented, it requires other infrastructure in terms of network connectivity, etc., so as to be able to verify registrations, which we've not accounted for in our model. And therefore, the actual capacities might be lower than what these baseline capacities suggest. The other thing that we've not captured in our model is any kind of variability. What I mean by that is, we've assumed that whatever storage capacity, whatever vaccine administration capacity is available in a deterministic manner, and that there is no uncertainty in their availability or the rates at which they can be used. Similarly, we've not captured any demand side uncertainty. And as you would know, having any variability in either available resources or demand would lead to a lower effective capacity than the base capacity. And therefore, you have to kind of take these numbers in with us, knowing that these are deterministic estimates. The other thing that we don't model as in this work is demand side factors such as vaccine hesitancy. As you have seen, there are regions, there are specific pockets in the country, there are specific population groups where there is a higher degree of vaccine hesitancy, that is uncertainty about the effect of the vaccine, and therefore less willingness to be vaccinated, which would then obviously also mean that your actual rate of vaccination would be lower. And also some of the same resources that are required for vaccination, which is these, especially the human resources like the ANMs, they could potentially also be involved in demand generation activities, which is to go canvas in, especially in rural areas, go canvas in house to house, door to door, informing and educating people about the benefits of getting themselves vaccinated against COVID. And obviously that takes time and effort, which means that time and effort is not being spent on delivering vaccines, and which would then again mean that effective vaccination capacity would come down. So we've not captured that either. And the big reason why we couldn't do that is just lack of data. And but still, a deterministic model such as the one that we've developed here is informative in terms of figuring out whether a prioritization strategy, which prioritization strategy is better and which might not be better. Right? Any questions?
There are two, Shripad. One is that if losses were accounted in your model, I think it's talking about wastage of vaccines.
Yes, we have accounted for that. So the government had a certain wastage rate that was built in. We've taken that into account.
And the second question is that does the model does not differentiate between private and public supply of vaccine, like quantity, distribution channels, prices, etc. vary?
No. So in terms of cost effectiveness, this is probably something that I should have clarified up front. What we are trying to estimate is, think of it as the net cost. So if I think about, for example, in India, if you were to go to a private hospital to get yourself vaccinated, then you pay a certain fee as the beneficiary, and this is paid to the hospital. Now, from a societal standpoint, this is just a transfer of money from you as an individual to the hospital, right? And so there is no net economic cost being incurred. The net economic cost is being incurred in actually having that vaccine delivered up to the hospital and in having that vaccine be administered. And those are the costs that we capture as part of this model. The other thing that we have, and all of our model, supply chain model especially, is under the assumption that only the public health infrastructure is being used for the delivery of COVID vaccines, both in the urban areas and rural areas. Now, in rural areas, this is a good approximation because urban private healthcare facilities are sparse in rural areas, especially the kind of facilities that are required for the delivery of COVID vaccines. Urban areas, of course, there are private hospitals that are doing vaccinations, and there is enough capacity, but just lack of data prevented us from being able to capture that effectively now.
There's a follow-up question on whether any cold chain failure reported from rural areas.
To the best of my knowledge, not really. In terms of, let me rephrase that. I don't think there was any systematic difference in the failure of cold chain equipment in rural versus urban areas. What is more likely is just the availability of the cold storage equipment in rural areas.
Sure, I think you can move ahead. Thank you.
In terms of the supply chain for COVID vaccine delivery, the big difference is in terms of the frequency at which vaccines are transported across the different stages. So for routine immunization, because it's a schedule based, you have very good prediction of what the demand is, and there are specific timelines. It's okay to transport them at lesser frequency to leverage economies of scale. But given that in COVID vaccination, time is of the essence, and sooner a larger section of population is vaccinated, better it is. The frequency at which vaccines were being shipped across different stages was much higher. And at least based on our conversations, on average, every week vaccines were being moved from the state vaccine store to district vaccine stores and further down to the cold chain points. And again, from the cold chain points on to the actual vaccination session sites, this was being done as and when the sessions were being held there. Now, in terms of how the supply chain is modeled for the COVID vaccine delivery, in the baseline, what we assume is for every cold chain point, the resources are as they are currently deployed. And part of it is utilized for routine immunization, and some of it is available for COVID vaccination. And same goes for district vaccine store and the state vaccine store as well, right? Now, given the current configuration of supply chain resources available, the available supply for the state is allocated optimally to different geographic areas. Think of those as supply allocations to each cold chain point, which could then determine how many sessions needed to be held and then take the vaccines further down to the sessions. Now, in terms of what I mean by optimality, our objective, we developed an optimization model where the objective was to minimize the number of unvaccinated person days. Now, the total number of unvaccinated person days is a sum of unvaccinated rural person days and unvaccinated urban person days. So for example, if today there are 100 people who are unvaccinated, tomorrow there are 90, and day after tomorrow there are 80, then the total number of unvaccinated person days would be 100 plus 90 plus 80, 270. Now, these 270, some of them are in rural areas, some of them are in urban areas. Now, in our objective function, we give a higher weight for rural unvaccinated person days if what we're trying to capture is a rural first strategy. Because again, rural first means you want to prioritize rural people, and therefore giving them a higher weight would lead the optimization model to have a higher supply being allocated to rural areas. And conversely, if it was an urban first strategy, then there was a higher weight given to urban unvaccinated person days. And they were both given equal weights under the uniform strategy. And the decision variables we considered in an optimization model was, as I said, the supply allocation in each period to each geographic unit and the vaccination rate, because the vaccination rate would then determine how much of the available resources would be used. And the constraints obviously were the total supply available in each period across the entire state and the resources available at individual geographic units. Now, in the aggregation scenarios where we allow resources to be moved, an additional decision variable was modeled, which is how do these resources get reallocated across different geographic units. So think of it as resources from different cold chain points being moved to other cold chain points depending on the need. And similarly, at the state level aggregation scenario, potentially resources at a district vaccine store being moved to other districts, and resources being moved from cold chain points in one district to cold chain points in other districts. And so we model an additional decision variable for the aggregation scenarios, which is in addition to supply and vaccination rates, how much of the resources to reallocate in each period. And consequently, the constraint is modified from resources available at a local geographic unit to the resources available in aggregate, either at the district level or at the state level in total. I hope that was clear. I can pause here for questions.
One question, Shripad, is that was hoarding of vaccine at local level as a variable important for this model?
So, can you clarify what you mean by holding vaccine at a local level?
So maybe, sorry, we can unmute and speak your question.
Sir, I was talking about a constraint in terms of sometimes it happens that the vaccine is locally hoarded by certain spurious persons, and that creates a a supply constraint in terms of demand being high and supply being low. So that fact normally while delivering a vaccine, do we take into consideration that certain percentage of supply would be lost due to the hoarding of the vaccine?
Oh, so you mean vaccine hoarding? No, we did not. Again, we did not factor deliberate actions such as certain actors hoarding vaccines and denying these vaccines from being available to regions that might be needed. What we did account for was wastage of vaccines because of vials that are opened but cannot be used and therefore are expired and therefore have to be discarded.
Okay, sir.
So with using this supply chain model for estimating capacity and the supply projections, what this graph here shows is the coverage of vaccination over time under the rural first strategy. So let me take a couple of minutes to explain what this graph is doing. So on the y-axis is the percentage of the target population that's vaccinated, and on the x-axis is the timeline from the start of the vaccination. So think of day 0 as 1st of April, and then therefore 150 days is 5 months after April of 2021 and so forth. Now the solid red line here indicates the vaccination coverage of the rural target population. And so what this solid under the baseline scenario. So what this solid red line says is by about 120 days, which is about, think of this as close to 3.5–4 months, about 40% of the rural population had been vaccinated. And by October of 2021, all of the target rural population had been vaccinated. And similarly, the solid black line represents the vaccination coverage of urban population. Now, given that we're considering a rural first strategy and there is adequate capacity even under the baseline scenario in rural areas, the vaccination of urban populations does not start until all of the target rural population has been vaccinated. Therefore, the first time that urban population starts getting vaccinated is sometime in October of 2020. The other thing, as I shown earlier, is under the baseline scenario, the urban vaccination capacity is lower than the supply available, and therefore vaccination proceeds at the capacity, and it takes till about May 2022 to finish covering the target population in urban areas. And so if you want to think about it, in rural areas, you have a supply constrained situation, whereas in urban areas, under the baseline scenario, you have a capacity constraint situation. Now, the dashed lines represent how the vaccination coverage changes with time under when we allow for aggregation and redeployment of resources. That is, we allow for resources to be moved across and used where they're necessary. Given that under the baseline, there is enough rural vaccination capacity, it doesn't make any difference to the rural vaccination coverage. However, it does speed up the urban vaccination coverage. Because once rural populations have been vaccinated, you could move those resources to urban areas and leverage all of the vaccine supply that's available and use it at a faster rate and finish vaccinating the urban population sometime around late January 2022. And so in that sense, allowing for redeployment of resources helps speed up the vaccination of urban population considerably, even under a rural first strategy. Now, clearly, given that in urban areas, capacities are constrained, under the baseline, it again takes from April till about October under the urban first strategy to cover urban areas, as this solid black line here indicates. Now, because in urban areas under the baseline scenario, you have a capacity constraint, not all of that supply is being used. And therefore, the remaining supply can be used to start vaccinating rural populations in parallel, because your total objective is to minimize unvaccinated person days. And given that rural unvaccinated person days also contributes to your objective function, rather than let that supply go waste, you can use it to start vaccinating urban population, albeit at a much smaller rate. And therefore, under the baseline scenario, you would find simultaneous vaccination of urban and rural populations, at least till October of 2021. And after that, given that all urban population has been vaccinated, all of the supply can be allocated to rural areas and all the supply can be used to vaccinate urban rural areas. And that goes on till February of 2022. Now, clearly with aggregation, you can increase the capacity in urban areas, take advantage of all the supply that's available and finish vaccination faster. And with aggregation, you can finish vaccinating urban populations by August of 2021, which also means you have no vaccine available to give to rural populations simultaneously. And therefore, the start of vaccination of rural populations is delayed till August of 2021 under an aggregation scenario, but it still takes roughly the same time to finish vaccinating. So under the baseline, and aggregation scenarios, rural populations get vaccinated, fully vaccinated by February of 2022. However, the manner in which this vaccination progresses is different under the two scenarios. And finally, when we consider a uniform strategy where supply is allocated to both rural and urban areas in proportion to the population, at an aggregate, you are supply constrained, and there is enough capacity in either of these locations to handle the amount of supply that becomes available when allocated proportionally, and therefore aggregations makes no difference whatsoever, and you finish vaccinating your entire population by around January of 2008. And so this is how the profile of vaccination coverage with time varies across the different prioritization strategies and under the different supply chain scenarios that I showed you initially in the slide. I can pause here, answer any questions.
One quick question, Shripad, that I was having. Did you see the impact of these on the secondary infections?
I'll come to that in just a second.
Okay, great. There's one more question, is that was micro-containment zones an impact on the vaccine speed of coverage also taken into consideration?
That's a very good question. I think the comparator we have is no vaccination. And I don't think in the epidemiological model, we also considered these non-pharmaceutical interventions such as containment zones and lockdowns and such.
Sure, Shripad, please go ahead.
So the second output of the supply chain model was the cost of implementing each of these strategies under the different scenarios. And we did this the same way that we estimated the cost for the routine immunization framework, where we know how much utilization of each of these resources costs, and we know what the utilization is for delivering COVID vaccines, and therefore we can estimate what the cost of delivery is. I say cost of delivery because this does not include the cost of the vaccine itself. And therefore, which vaccine is being delivered does not influence these cost estimates at least. It would influence the total final cost incurred by the government, but that's not what we're interested in. What you will notice is the cost of delivery is not significantly different across different strategies, and neither is it different across the baseline and district level aggregation. And where there is a difference is under the rural first and urban first strategy. So aggregation has a slightly higher cost, and this is understandable because it is under each of these two different strategies that you would actually end up moving resources, and therefore you would incur the cost associated with moving resources in addition to the regular cost of delivering vaccines. And these are the unit costs, which are about $30 to $32. And in total, when aggregated across the entire state of Punjab, the cost of delivering vaccines is ranges from about 94 to 97 crores. And so aggregation leads to a marginal increase of about 3% over the baseline costs. And so in terms of at least the cost of implementing each of these different strategies, there isn't a vast difference. And so to determine which is more cost effective comes down to trying and understanding which of these strategies results in a better health outcome, which is what I'm going to talk about next when I discuss the epidemiological model. And again, a big caveat here, I have very basic knowledge about the modeling, and I'm going to present what I know. And if there are questions, if there are suggestions from people who have expertise in this area, please let me know, and I can always take this up with my collaborators and bring this up in a discussion, and that'll help us improve our modeling. So the epidemiological model, in brief, is essentially a transmission model for the disease. And what I've shown here in this picture is what is called as a compartmental model of disease transmission. So the S here stands for susceptibles, E stands for exposed, I is infected, and R is recovered. And Q is people who are, think of these as people who are in quarantine or isolation. And so to that extent, home quarantine is captured in the transmission model. And it is a deterministic model again. What it models, so these rates here that you see, lambda, eta, etc., are the rates at which susceptibles become exposed to infection, and exposed individuals end up becoming infected. And gamma here captures the rate at which infected individuals recover. And these are the different proportions in terms of how many people end up with quarantine, and what are the fractions between quarantine and severely affected. Right? So think of these IN as non-symptomatic and IS as symptomatic infected individuals. Now, this model was stratified by setting. So obviously these rates of getting exposed and infected are different between rural and urban areas because of a variety of different factors, including population density, the demographics. And that's also captured. And this is also a model that's stratified by age group. So the transmission dynamics are different in children, it's different in adults, it's different in elderly, especially in terms of what the severity of disease is. So this transmission model is stratified and tries to capture all of it, right? And only the number of infected individuals within each of these stratified models contribute to the force of infection. So that's the transmission model in brief, and I've tried to convey what I know about this. And the way you solve this is through a system of differential equations, and there is no closed form solution to these differential equations, so it has to be solved numerically. So here's what we find, right? What I have in the picture here is, on the y-axis is the daily symptomatic incidence of disease per 1,000 population in the state of Punjab. And so the transmission model was calibrated to what was observed in the first wave. And what this model is trying to do is, if a second wave were to occur with similar transmission characteristics, what would the impact be, right? So the dark blue line that you see here is in a scenario where there is no vaccination happening. And so if no vaccination happened, then how would the number of infections vary over time from the beginning of the second wave? The red line is how the disease incidence would change if one were to follow a rural first strategy. The green line is if one were to follow an urban first strategy, and the yellow line is if one were to follow a uniform vaccination strategy. And all of this is for a model which tries to simulate what the actual vaccine immunization was. What I mean by that is, if you think about it, vaccination was roughly opened for general population around the time of April. And so if one were to implement these strategies with vaccination beginning around 1st of April, then what would the reduction in incidence of incidents and mortality be under each of these different vaccination strategies? So what these results suggest is they are fairly comparable, and based on the actual vaccine immunization, it would have resulted in about 10% lesser incidence of disease and about 14 to 13% reduction in the mortality because of transmission. Any questions on this before I move forward?
There is one question, Shripad, which is there any ill health or cost of a slower pace of vaccination?
That's a good question. I don't think we model it here because we assume that the capacity and resource are as given. But that's if, let's say, for any reason, the actual vaccination pace was much slower than what these estimates suggest, then that would definitely have an impact on what the effectiveness of each of these different strategies is.
Great. Thank you. Thank you, Shripad.
What we model as a counterfactual is what if the vaccination happened earlier in terms of compared to when the second wave occurred? So we don't change the actual date of vaccination, but what we model is a delayed onset of the second wave. And so compared to the actual vaccination, which was, so if I think about the actual scenario, if you think about the time between when the peak of the pandemic second wave was versus when the vaccination began, it's a little about 1.5 months time gap. Instead of that, if let's say the gap between when vaccination started to when the beginning of when the second peak of the second wave was a month more, then what would have been the impact of following each of these different strategies? And what we find is under a rural first strategy, you'd have had about 24% reduction in incidence and about 27% reduction in mortality. And similarly for urban, it's slightly lower, uniform, it's slightly lower. However, what I would point out is these numbers that you see in the brackets below the 11.2, 11.9, etc., are the confidence intervals. So these shaded regions that you see are the confidence intervals of the disease incidence associated with each of these different strategies. So in that sense, what you will notice is that the confidence intervals across all the different strategies are overlapping. And so to that extent, there is, even from an epidemiological perspective, there really isn't much to choose from in terms of the strategies, given the current vaccination capacity and supply that's been available. And so however, what is interesting to note is that an earlier vaccination would certainly have had a significant impact in terms of reducing mortality. So you would have had 20% lesser deaths compared to no vaccination, as opposed to only about 14%, given how the vaccination actually went ahead. And so given that we see a benefit of earlier vaccination, we also did a sensitivity analysis in terms of trying to understand what would be the impact of each of these different strategies as a function of the time between when vaccination started to when the second wave peak was. So think of it as if, let's say, the time was only 40 days, then under each of these strategies, you find about 15 to 16% reduction in cumulative incidence because of vaccination. So there is limited effectiveness, but there is effectiveness. Whereas if, let's say, the vaccination had started 6 months before the actual second wave peak occurred, then under a uniform strategy, you would have been able to avert pretty much most of the incidents that would have occurred. And the urban first and rural first strategies would have had lesser effectiveness. And the way to think about it is 6 months ahead of the peak of any second wave, there is nothing much to choose in terms of, or rather, prioritizing based on seroprevalence would really not mean much, because by the time the second wave starts and reaches the peak, any benefit that you would have gotten because of antibodies from a prior infection would more or less be nullified. And therefore, not giving vaccines to one group of population and withholding it from them would have exposed them unnecessarily, and therefore would have prevented them from being susceptible to infection, right? And therefore, following a uniform strategy and ensuring everyone is equally covered leads to the highest benefit. And this is all under the baseline scenario where resources are not being moved across different locations, right? And the benefit, if one were to allow redeployment of resources within the district, it's actually not uniform. In the sense, if you think about an urban first strategy, when you move resources away from rural areas to urban areas, if there is not a significant gap between the start of vaccination and the peak of the second wave, it can actually end up hurting you. And the reason why it hurts you is because you're denying vaccines to one large group of population, which is the rural population, and therefore they are more exposed and the disease takes root and therefore causes more incidence there. Any questions?
Yeah, Professor, there is a question on the chat box.
Yeah.
Does this model cover the vaccine's efficacy even after 4 to 5 months of dosage?
So what we have modeled in the transmission dynamics is that anyone who's vaccinated we've modeled a vaccine efficacy of about 60%. And we've assumed that it's 60% throughout, and there is that it doesn't attenuate with that. Because there is still evidence coming in terms of how long these different vaccines are effective for, how long does the protection last, and so forth. So we just, given that numbers as high as 95% and 96% are being quoted, on the conservative side, we assume that the efficacy was about 60%. Does that address the question?
Yeah, it does. Yeah.
Okay. I know that we're running out of time, so I'm going to conclude quickly. So finally, we've seen what the health outcome impact of the different strategies are. We've seen the cost impact. And what we are interested in is the cost effectiveness of these different strategies, right? And what we include in our cost effectiveness are obviously the cost of delivering vaccines, which is the supply chain costs, and the cost of redeploying resources based on the scenario. And on the other side, we include costs of healthcare utilization for those who are infected. So think of people with mild symptoms. What is the cost implication of these patients? And for those with severe symptoms, what is the cost of hospitalization and ICU care where it is required? And some of these costs, healthcare utilization costs, have been taken from published studies which have tried to measure this. And what we find, and these are estimates of costs and cost effectiveness under the actual vaccination scenario that I showed you earlier. So all the bars that you see on the positive side are the cost of delivery, and all the bars that you see here on the negative side are the costs that are avoided because of lesser incidence of the disease due to vaccination. And these cost savings are again segregated by different age groups. So the red bars indicate the healthcare costs saved for people less than 18 years. The yellow bars are for people in the 18 years to 65-year category, and the purple bars are for people who are above 65 years. And so again, as you will see, across the different strategies, the costs that are avoided is not significantly different in total when you add up across all these three bars together. However, under each of these strategies, the biggest saving of costs comes from the 18 to 64-year-old population. And then if you break down the cost savings in this age group, what you find is the major cost avoided is that of hospitalization. So think of these as people with severe symptoms who needed hospitalization, and because of a lesser incidence of the disease, you can save those costs. And that forms about 75% of the total cost that's saved due to vaccination. And so the major takeaway from this is, even if implemented late, vaccination has significant benefits and can be cost saving. So some limitations. The tendency is to kind of think about whatever a model says as predictions, but that's not the case. These are just projections. And our model is limited based on the assumptions that we've made. Specifically, we do not capture vaccine hesitancy, and that will have an impact on how much coverage can actually be reached, and therefore what the impact of vaccination is. What we also did not model in when we did the cost saving estimation is constraints on hospital and oxygen availability. And so if these factors were captured, then it would have led to a significant increase in the amount of cost that was saved because of vaccination. And the other big caveat is all of these model projections are specific to the seroprevalence and transmission dynamics that were observed in Punjab, and they can't be extrapolated to other states or other conditions where the disease dynamics could be very different, right? What they do illustrate is seroprevalence-based prioritization may not be ideal. And this is especially true given that there is a fair bit of uncertainty associated with future epidemic progression. So for example, even if you've been infected in a prior wave, the second wave could have variants that are spreading it, and therefore it's not clear whether seroprevalence and antibodies from a prior infection, how effective they would be, etc. And given all of these uncertainties, it is probably better to follow a uniform strategy where all people at risk are uniformly vaccinated. Right? Yeah, so I'm just echoing what I just said on the earlier slide, which is given the uncertainty about the second wave dynamics, as well as when it is likely to occur, a uniform strategy would be well advised. And finally, the message is mass vaccination against COVID is cost effective and cost saving, even if it is implemented in the middle of a pandemic, as was the case in India, where the vaccination was happening alongside the second wave peak. Right? And the major driver for cost saving is the averted hospitalization costs. And early vaccination clearly pays dividends. Thank you. And if you need more information about other aspects related to COVID vaccination, COVID management, and more details about this study, these are some places that you could go to. That concludes my presentation. I know we're already over time, but I'm happy to see if there are any questions and address those if the organizers allow for it.
Thank you, Professor Shripad. We have answered all the questions in the chat box. So if anyone has any more questions, please go ahead and unmute yourselves and you can ask. Yeah, looks like all the questions were asked during the presentation itself.
All right.
So if there are no more questions, we can call it a day. Let's thank our speaker. Thanks again, Professor Shripad, for taking time out to present your work related to the cost effectiveness of vaccination strategies at the RNP seminar series at IIM Ahmedabad. And thank you all for making it to the seminar.
Thank you, Maya, and thanks once again for the invitation, and my apologies for going so over time.
No, I think it was because of the questions as well. So,
sure.
Thank you, Professor.
Yeah, and I suppose my contact details are available. So if any of you have any follow-up questions and would like to know more, then please feel free to drop an email, and I'll try my best to address those. Yeah, thanks so much, and have a good weekend.
Thank you.